Thank you very much, Dr. House, for the introduction, and SSAT leadership for the privilege to present at this forum. I am currently a medical student at the University of Connecticut, and I was previously a Harrison Surgical Scholar at the University of Pennsylvania. And today I'll be presenting our insights as to how blood loss affects pancreatic fistula development. We have no disclosures. So the beneficial effects of reducing blood loss have been demonstrated in multiple surgical domains, including pancreatic surgery. Collectively, these reports suggest an actionable opportunity for quality improvement. Specifically in the case of pancreatoduodenectomy, reductions in blood loss have been associated with decreased rates of any and severe complications, intraoperative transfusions, shortened lengths of stay, readmissions, and 90-day mortality. Surprisingly, though, blood loss has not yet been incorporated into many standardized surgical databases. However, when as a variable, we have shown that it can enhance the NSQIP surgical risk calculator's ability to predict procedure-specific complications for PD. Moreover, elevated blood loss is an integral component of the widely applied fistula risk score. For a quick review, these four elements are the pillars of the fistula risk score: a weighted 10-point scoring system which offers quantitative risk assessment for clinically relevant pancreatic fistula. Notably, it is evident that blood loss contributes up to 30% of this score. Pertinent to later in the presentation, please recognize that each risk point is associated with an approximate 300 milliliter range. Furthermore, 4 discrete risk zones with escalating fistula risk have been characterized, ranging from the negligible to high risk zone, where fistulas occur close to a third of the time. But beyond risk zones, this can be taken to a more granular level. We call a scenario the collective combination of the 4 elements of the fistula risk score. More simply put, a scenario is a patient's exact combination of gland texture, pathology, duct diameter, and blood loss. Using this framework, there are 80 distinct fistula risk scenarios representing biological uniqueness, which is evident both in variability of a scenario's occurrence and its associated fistula rate. So given this background, we aim to more thoroughly investigate the role intraoperative blood loss plays on fistula development. To do this, we utilize 5,500 cases from the Pancreas Fistula Study Group International Collaboration. Our primary outcome study was clinically relevant fistula as per ISGPS standards. Blood loss was progressively categorized into 4 cohorts. The impact of blood loss was analyzed in the setting of isolated risk factors as well as endogenous risk scenarios. We then calculated how reductions in fistula could hypothetically be obtained by limiting risk attributed to blood loss. Multivariable regression analyses were used to identify factors associated with fistula and blood loss below the median of the series. Finally, surgeons were ranked by median blood loss in reference to their fistula rates. Here's what we found. Importantly, fistula rates double across the advancing blood loss cohorts, which was even more pronounced in the 55% of patients with soft glands, where the rates tripled across the progression. Furthermore, severe grade C fistula rates also escalate across the spectrum of blood loss. And again, this was accentuated in patients with soft glands, reaching up to 10% when blood loss exceeds a liter. But is it just about a single risk factor alone? We'd argue that fistula risk is multifactorial. In fact, in a recent international survey, 14% of surgeons believe risk was attributed to only 1 risk factor, 26% of surgeons believe 2 risk factors were in play, and the overwhelming majority of surgeons, 61%, believe there are 3 or more factors contributing to fistula risk. Finally, most surgeons reported that they believe glandular risk factors were the most prominent drivers of risk. So, to quickly analyze the intersection of various risk factors, we'll first focus on small duct size, where the fistula rate is 15.7%. When we look at soft gland texture, the fistula rate advances slightly. However, when these 2 factors are combined, the profile increases, but not synergistically. Furthermore, when risky pathology is in play, the fistula rate is further increased. Now, when we add the 4th factor, namely blood loss, you can see that you've doubled your original appraisal of risk. This pyramid offers insight to the biological interplay of risk and underscores the importance of considering collective risk in accurately predicting fistula. Switching gears, let's get back to the concept of risk scenarios. We suggest a concept of endogenous risk composed of the 3 FRS risk elements specifically associated with the pancreatic gland. If you think about it like that, the previous 80 scenarios can now be consolidated into 20 distinct combinations of these three elements. Here, we segregate fistula rates when blood loss is below or above the median of 400 milliliters, which coincidentally aligns with the threshold for FRS blood loss point accrual. Notably, 13 of these 20 situations demonstrate increased fistula development. Furthermore, nearly every scenario predicated on a soft gland demonstrates increased fistula incidence when appreciable blood loss is involved. Now, when considering statistically significant differences, two major points are evident. First, and quite interestingly, in the setting of negligible endogenous risk, blood loss in itself contributes to fistula development. Secondly, at the highest end of the endogenous risk, scenarios composed of a combination of soft gland and other risky pathology with smaller duct sizes had significantly higher occurrences of fistula with escalating blood loss, indicating a possible synergistic effect within these most vulnerable situations. Finally, summated data across the whole series of scenarios demonstrate that blood loss greater than the 400 milliliter threshold results in a significant increase in fistula occurrence. Following the previous analyses, we want to calculate hypothetical reductions of fistula that could possibly be obtained by limiting blood loss. This projects that significant reductions in fistula can be obtained with 1, 2, and 3 point deductions in FRS points attributed to blood loss, reaching a potential 20% improvement. This is especially pronounced in the cohort of high-risk patients who might afford up to a 31% abrogation if blood loss can be curtailed. To further substantiate the relationship between blood loss and fistula, a multivariable regression was employed. Notably, along with typical glandular features and other detrimental management approaches that we have previously reported, blood loss demonstrates a dose-dependent relationship. Furthermore, we found that increasing surgeon experience was independently associated with a decreased fistula occurrence. Next, we analyzed factors associated with blood loss below 400 milliliters. And again, surgeon experience appeared to be impactful, indicating that limiting blood loss may be controllable. However, and counterintuitively, more experienced surgeons were associated with greater blood loss. Finally, when analyzing individual surgeons' blood loss and their associated fistula rates, increasing median blood loss was associated with an escalating fistula trajectory. Specifically, surgeons in the lowest quartile cohort of median blood loss had significantly lower fistula rate at 8% compared to surgeons in the interquartile range cohort at 14%, and less than half of that of upper quartile surgeons at 19%. In a quick review, blood loss independently contributes significant risk to fistula development and its burden, particularly in more biologically vulnerable scenarios. Substantial reductions in fistula occurrence are projected by minimizing blood loss. Unlike well-recognized immutable inherent risk factors for fistula, blood loss appears to be an actual target for improvement. Future studies should be directed towards investigating the mechanistic effects governing the interplay between blood loss and fistula occurrence. In conclusion, these data advocate for limiting intraoperative blood loss to ensure the endogenous risk for fistula development is not further accentuated. I'd like to thank each of the members of the Pancreas Fistula Study Group who contributed to this project. We are indebted to our collaborative group whose tireless efforts have allowed for many of our studies on fistula. I'd also like to thank the chair of the Department of Surgery at the University of Pennsylvania, Dr. DiMatteo, as well as my mentor, Dr. Vollmer, for allowing me to study as a Harrison Surgical Scholar. Thank you. I'd be pleased to entertain your questions.
Very nicely presented and elegant work, Max. The primary discussant for this nice paper is Dr. Garland Kledzik from John Wayne.
Hi, I just wanted to congratulate Max on a great presentation, and I'm just especially impressed by him as a first-year medical student. He knows a lot more about surgery than I did, probably even in my third year of medical school, so I'm just very impressed. This is a really interesting study, and I have a couple questions for you. The first one is, can you comment on the relationship between surgeon experience and blood loss and why you think it's counterintuitive that the more you operate, the more blood loss you have? And then you mentioned that this is a targetable end goal to change surgeon blood loss with better techniques or things like that. How do you think that we as surgeons can improve this, especially in an era where surgical training and autonomy is diminishing?
Yeah, thank you, Dr. Klesik. Those are great questions. I think I'll approach the first one, which was our initial confusion at first too, that more experienced surgeons are associated with higher blood loss. We believe that this might be something that our database fails to capture, and more experienced surgeons taking on more complicated cases that are more prone to blood loss. We also believe that it might be confounded by usage of high energy devices. One thing that I would like to emphasize though, is this is focusing on patient with soft glands. And you can see this interesting relationship between surgeon experience and blood loss. So while I said the younger surgeons are more likely to have lower blood loss, it's also important to emphasize that blood loss for this cohort of surgeons appears to be more impactful. As for the second part, in terms of practically reducing blood loss, our group is working on a study right now emphasizing these points, and some of the major things that we thought were important were a more meticulous dissection, use of high energy devices, and really getting good exposure of both your arteries and your veins in your surgical field prior to completing the actual resection of your pathology that you're dealing with. And this will be especially important in cases that will ultimately require vascular resections. Thank you again for your questions.
I'll open it up. Max, if you could stop sharing your screen there, this should allow us to open it up for any other comments from members on this call.
Hey, Max, Clay Merritt here. I have a question for you about how the blood loss was recorded. There's a lot of information that shows that, surgeons' estimation of blood loss can be pretty inaccurate. Anesthesia's estimation can be inaccurate. So for this study in particular, how was it estimated?
Yes, great question. Thank you. Blood loss was recorded by the attending surgeons in consultation with the attending anesthesiologist. We would agree that previous studies have shown that blood loss might be unreliable, and there certainly is a variation in how it can be recorded. But we believe that using a categorical variable with large ranges does allow for millimeter to millimeter resolution to be overlooked and allow for some error while still providing value as a quality metric for assessment.
So Max, I have a question for you and help the audience understand, why did you pursue exploring the estimated blood loss? The last comment I think was very appropriate, and there's a huge variability, as you know, and didn't focus more on the need for transfusion, either intraoperatively or shortly thereafter, and intraoperative fluid management. Because I think probably the underlying hypothesis is that blood loss correlates with the need for more major resuscitation, thus leading to visceral, including intestinal edema, which could be an indirect surrogate marker or predictor of fistula.
Yes, I think those are great points. Thank you very much for those comments, Dr. House. I imagine that if we did analyze intraoperative transfusions, fluids from resuscitation, we'd find that there's a high collinearity with blood loss. So we decided to focus solely on blood loss, as we believe it's more so worthwhile in terms of proposing an opportunity for surgeons to focus on something during their operation, which will also reduce the downstream effects that come with it. But I can agree with you that blood loss is definitely a surrogate marker, and it's hard to prove if the blood loss is leading to fistula versus if the mechanistic effects governing fistula are from hypoperfusion, resuscitation, or immunosuppression from the transfusion. We should look into that into the future to really understand if blood loss is absolutely the end-all be-all independent factor causing fistula.